Hello, and welcome to Hopkins at Home. My name is Tamar Rodney. I'm an assistant professor at the Johns Hopkins School of Nursing. I'm also a psychiatric mental health nurse practitioner with a clinical practice in Baltimore City. Now, part of what I do is to look at trauma in different aspects of life and looking at how it relates to mental health disorders. And today, I want to talk to you a little bit about trauma in a different light, that of COVID, entitled in a talk we'll call Trauma, the Wounds We Cannot See. Now, during the presentation, if you have questions, please feel free to type those in a chat box and we will address them as we go along. And at the end of the talk, we will have some time as well to address those. So I'll share with you first this photograph of a picture, red circle, and maybe 2 years ago, we wouldn't have known what it is. And what is it? It's actually a pictorial representation of COVID-19 virus. Now, what is good about this is that we know what it is very easily. What is bad about this is that we know what it is without being told. My question is something benign as a picture with little protein representations on it can tell us so much about a year of what has not been a good experience. But what is troubling for me is when I think of this is what will our memory of this photograph evoke in a year or 2 years from now? What will this picture mean to you? In some respect, this is representative of how trauma evolves. There's an event, we might not see it, and maybe the repeated exposure, like what we're going through with COVID-19, will essentially evoke some memory, maybe good or bad, or somewhere in between, which we're not able to see. And another metaphoric value of this picture is, yes, we know the symptoms of COVID, but in everyday life, we're not able to see what this actually looks like. And it's only through multiple electronic magnification we can get a picture like this produced. And so much of it is unseen. And traditionally, we speak of traumatic events as physical, of fire, of blood, violent altercations. But in this term, emotional trauma are ones that are not seen but experienced in an emotional or deeply personal level. So let me start with this quote it's from a book series called The Minstrel's Kiss. And it reads, "There are wounds that never show on the body that are deeper and more hurtful than anything that bleeds." And part of my work with mental health is trying to find out what are these wounds that individuals carry around with them on a day-to-day basis that you're not able to see. And having worked in trauma, I know the stark difference between seeing something you can treat versus not seeing something which needs to be treated. And probably the most simplistic representation of this is that if you have a cut, you could put a Band-Aid on it, and everyone knows that that's an area of tenderness, and so not to disturb it. Similarly, if you have a broken knee, there's a bandage that you wear. And after that healing process takes place, there's a scar. And we know what happens, but it's healed in some respect, and others and yourself can view this. Now, with mental health trauma, traumatic experiences, these scars still exist, but they're so deeply buried, not acknowledged many times, and it's assumed that an individual might be okay. So when we speak of COVID in the context of trauma, I want to think about it in what are the items that are being absorbed by an individual, scarring probably their existence, never spoken of, but still leaves a wound that needs to be addressed, needs to be mended, needs to be healed. And how do you get there? And how do you see what this individual is experiencing? So there are many ways to look at how an individual experiences trauma. And I'm going to share with you two models today, which try to give a good shot at how this is experienced. The first one is called the diathesis stress model. And in essence, it says that Everyone is born with a predisposition or a vulnerability to life, to events, to traumatic outcomes. But what makes this model come to an impact or an outcome is the environmental stress that an individual might face. Now, the outcome or impact doesn't need to be the same, but it is a combination of these two things that experience in the same time can produce variable outcomes. In a perfect world, most individuals are resilient. So you will go through an event and there is a process of coping. You learn how to cope with it. It's almost like the grief process. And essentially what you're hoping for, what is expected at the end of that process is healing. Yes, it has happened, but you have somehow found all the capabilities to heal. That's an ideal sense, and that's what we hope for. Now, I want to share with you a different model. And this one is called RAM, or Raw Adaptation Model. And at the core of this is the word adaptation. Now, this model says that human beings are very complex individuals, as we are, but it takes into account a biopsychosocial process. So within our bodies, if a stimuli enters, in this case, a traumatic stimuli, we again use this all everything around us to cope. There's a coping process that the body, the mind, the spirit goes through. But what is different about this model, it says that the outcome is a behavior. So if you look at the centerfold piece here, it seems pretty simplistic: in, process, out. But what is different is what is that behavior on the end of that coping process? Now, there is an innate ability in human beings to cope, and there's different ways of coping. And what I want to get from this is, as scientists, as researchers, we look for things to make sense, and we look for models to explain or help us explain why things happen the way they do. In the last year, however, what has been a little bit disturbing to me, working with my patients, working with students, and even in our personal life, is that nothing about COVID fits uniquely into these models. What do I mean by that exactly? Is that both of the models I showed you termed an event, a stimuli. It's a singular event that happens, which produces an outcome. COVID-19, however, has been multiple series of events, and sadly, most of them have been getting progressively worse. So if we think back in March 2020, when it was first declared a global pandemic, yes, there is some scare. Yes, we thought about how many countries were affected. We thought about, how is transmission? Is it in the air? Is it by touch? And then the grim numbers started, 1 million worldwide, because it was important for us to think about the gravity of the situation. There's some talk of vaccines back in August, but we weren't sure how well it would work. So a little bit of hope, but not quite. And then the global death toll kept getting worse. And so the picture I'm trying to paint here is that no one really knew where this was going. And on the surface of it, things kept getting worse and worse and worse. And if you bring this back down to our day-to-day life and existence, there's an element of uncertainty and fear, because while we're trying to keep safe from the virus, it's very evident that individuals are dying. But it's not just the grim final outcome of death. In between, there's a fear of getting it. There's a fear of losing connection with individuals. We're being asked to isolate. We're being asked to wear masks. There is sacrifices that individuals are making on a day-to-day level, which are equally traumatic, comparable to the virus itself. And let's think where we are now in April, where there's vaccines available. And what do you know? We throw another ball into the court of variants. So I cannot confidently say that we know what the next 12 months will look like. What I would want us to acknowledge is that the last 12 months have been a recurring series of traumatic events, which I would want us to pay attention to. And so as I go through this talk, I want you to think of what has been, how we've coped, and what might the future look like, thinking of the things that we're not evidently seeing as scars of trauma. So in COVID, I would want to repaint this picture of a single event to what I'm going to call three different things that are going to impact the outcome. The first one is it's a recurring series of events. It's not knowing, it's injection of loneliness, injection of separation, and each of those events have been progressively worse. There's also the concept of historical trauma, which we want to pay attention to. And while historical trauma, by its definition, only affects groups of individuals, these are significant groups of individuals who are predisposed to a certain set of traumas, which ultimately makes every other traumatic event worse. Now, cumulative trauma is probably where COVID-19 and its outcomes are most loosely defined as a series of cumulative trauma. But what is important here is thinking of what are these other traumatic events an individual might have had in their lives? What are these events that they're having now? And what will, in colloquial terms, what will be the straw that breaks the camel's back? What is that one event that says to someone, I can no longer adapt or I can no longer cope? And it is within this realm that I ask you to look at COVID through these next contents of what are some of the unique characteristics of us as individuals that will help us to see trauma in a unique lens as well as protect ourselves. First component is age. Now, trauma and traumatic experiences can start at any age. And so within this context, I want to think about how it affects adults as well as children and how those behaviors are manifested. The next component is time and time on two continuums. Time is in the uncertainty of when it will end. We're looking for an end off to start healing. So if the onslaught will stop, then we will have a clear picture of what is it that has happened. But we don't have that. That's not something we have. But the other good thing about time is the phrase that time heals everything. We need time for the healing process to take place. And while it might sound a very gloomy picture, there are protective factors here as well. The difference is that there are different protective factors for different individuals. The example I'll share with you is the beginning of the pandemic, the guidance was that we need to isolate, physically distance ourselves, and this meant different things to different individuals. So in a household of five, social distancing meant that you have a supportive system of five individuals in your house. That is in itself protective because you can have the support of each other. In a household of one or two, it means that one individual or two individuals might be separated from the rest of their family members. And in some ways, it's protective, meaning that there's less chances of getting the virus, but it's also not protective because you've removed all that social support that individuals need when things are going wrong. The next lens I would like you to look at this is that things are experienced on a continuum. What I mean by this is that trauma is usually thought of as mild, moderate, severe, like how much can you deal with? The problem with looking at things as mild, moderate, severe is that, say, anxiety for me will be debilitating, whereas for you it will be something that you could shake off. So ascribing mild, moderate, severe to an experience is a very delicate balance between what it means generally and when we diagnose and come up with a number versus what it means realistically as experienced by an individual. Our next lens is that it's a reactionary process. So trauma itself means that you're going through something that you never asked for, want for, or you never prepared for in most instances. Except for few, there's traumatic events, maybe weather events that we could prepare for. Most traumatic events are not events that we can fully prepare for. So what we're doing is reacting. We're reacting to something, and very often our reaction is not equal to buffer that blow. And the last lens I would want to look at is that it's a very variable experience. The reason why trauma is experienced differently is because, maybe going back to the diathesis stress model, is that we react differently because of our innate vulnerabilities or predisposition. So, this is to say that a singular event can be experienced by a group of individuals, like what is happening with COVID, and the outcome and the response is very different. Different as well as varied. So I want to keep in mind that with these lens that we look at trauma, there's no clean stroke brush as to deciding what will be, which is part of what makes it so difficult to treat, to diagnose, and to accept. So I want us to hold these in thought as we talk about what is often followed up with trauma, which is post traumatic stress disorder, used very frequently in our language, but it means what it says. It's an event that happens after a traumatic event. It is, however, a diagnosable disorder, and this is part of my work that I do. So, by definition, I wanted to start here to say it's post traumatic stress disorder, or for short PTSD, is diagnosable when an individual will have a history of trauma exposure involving actual or threatened death or serious injury to oneself or others. And I just wanted to take a minute to point out that it's not just self, but it is to other individuals. So if I can perceive something bad happening to you, that traumatic effect could affect me. So, how do we classify history of trauma exposure and threatened death? So, it comes in four primary ways of looking at it. The first one is you as an individual is directly witnessing an event. And it's very clear with COVID that we're all individually witnessing this event. We can't escape it. We see it every day on the news and through social media and just through talking with others that this is an event that has permeated much of our lives for the last 12 months. Next, witnessing it happening to others. And this was primarily rewritten in how we diagnose PTSD from events of one of them was from 9/11, where there was an event in the city, but not knowing who it had affected was equally traumatic to individuals. And so this extended who PTSD is applied to by seeing it happening to other individuals that is equally impacting yourself. Our next one is learning that it happened to a close family member or friend, so someone you care for, that just hearing that they are going through traumatic experiences is also traumatic for you. And our next point is that if it's experienced repeatedly, like what we're going through now, having these traumatic details experienced over and over and over again is sometimes what produces the trauma. So maybe twice hearing about it is not so bad, maybe three times not so bad, but 10, and as well as the time component of having it for an extended period of time. So, what does this look like? Um, Diagnosable, it's done by a clinician, but it's experienced by a human being. And so I want to talk a little bit about what these symptoms look like. And by symptoms, I mean what are the descriptions of the feelings you face after having a traumatic event. And so for post traumatic stress disorder, symptoms or experiences of feelings are grouped into what is called clusters. And so clusters of symptoms. And there are four clusters in which most behaviors will fall. The first one is intrusion, meaning that there's something that is entering your thought or your emotional well being that is not welcomed. The other behavior is avoidance, meaning that you as an individual purposely avoid events, places, things. The next outcome is negative mood, and this is how you will react to things. It's in a negative manner as opposed to a positive manner, where previously it might have not elicited a reaction at all. And then being in a state of hyperarousal, which is always being on edge, is probably a good way to describe it, but it is not in keeping with an individual's regular everyday reaction to something. So I'll take a minute now to go through these individual clusters and how they might be represented in an individual's behavior. And the first one we look at is feelings of intrusion. So intrusive thoughts is one of the ways to describe this. So after going from traumatic events, one of the things that is frequently spoken about with PTSD are nightmares. It's one of the hallmark symptoms, and this is probably one of the ones that we think if we have a nightmare, then certainly something is wrong. But it's not the only thing. It could just be a thought that is distressing to you. It could be recurrent nightmares. Separate and apart from having flashbacks of an event, let's say that you've had to visit an individual who was, going through the depths of COVID, or you see photographs on TV, which is representative of individuals going through a difficult time. But with these reminders, there's an intense emotional upset at the reminder, and this can often be translated into an additionally physical upset at reminding you of events. So again, it's the presence of something which you would prefer not to be there, but are still experienced. And that's just one of our symptom clusters. Let's look at avoidance. And so avoidance is exactly as it sounds again, is that you avoid thoughts, you avoid feelings, you want to block them out of your mind. You avoid activities and places and situations that might remind you of a traumatic event that you had been through. Again, it might be the beeping sound of an oxygen tank or visiting the intensive care unit. It's things that you will purposely avoid to want to experience again. But this is done at a very purposeful level by the individual. Our next one is the negative mood. Now, negative mood means two things. It's you not being able to recall aspects or purposely refusing to recall aspects of a traumatic event. You've also lost interest in activities that you'd previously be interested in. So maybe shopping or playing games or enjoying an event with someone else. What this leads to is that you essentially become detached from others. I want to pause here just to make a point about feeling detached from others, because this is precisely what is recommended with COVID. So you're doing something which is a negative mood effect, might be a negative aspect of trauma, but for safety's sake, it's recommended. The irony is not lost for many persons who might want to protect themselves by engaging in that behavior. But there's also an impaired range of emotions. So things that you should be happy about, you're no longer happy about, or you have a very blunted effect at things. You just won't smile as widely as you would about a joke. And changing the things that you probably previously hoped or planned for. There's a less intense wanting to do things, and this eventually translates into futuristic things as well. And our last symptom cluster is looking at hyperarousal. Hyperarousal, many times sleep is often thought of, it's not hyperarousal, you're sleeping, but this is actually difficulty sleeping, difficulty falling asleep or staying asleep, which is frequently coined with having flashbacks and nightmares. But additionally, you find these individuals to be very irritable, very angry, and having difficulty concentrating, very alert and easily startled. Now, dare I say that none of these behaviors are behaviors that anyone would want to be around. But looking at these four clusters, what is very evident, at least from my perspective, what I would want to point out to you is that many of these behaviors can be done in silence on an individual level, and it is very likely that no one will ever know. Or they might see one, but they won't see the range of behaviors that an individual is experiencing. Coupled with this is that an individual who is going through one or two of these symptoms might try to make an explanation as to why it's going on. It's very new, but it's also very scary. It's very frightening to be going through these things, and the first thing you want is for it to go away. What is the ultimate outcome of having these behaviors? First, I want to think about it in general risk. And risk and description of disorders, particular trauma disorders, is done by the DSM-5. And this is one number that I am almost willing to say that must, would, or should change. Everything that says a lifetime risk of an individual going through a traumatic event and developing post-traumatic stress disorder is 8.7%. I cannot think of us going through this pandemic and all the trauma that comes with it that this number might not be higher, at least for the next 12 months. I want to go back to this concept of time again, about what is the best outcome. The best outcome is actually that you go through an event and you recover. 3 months is actually one of the key markers here, that in a normal setting, an individual might start experiencing symptoms within 3 months of experiencing something. So we're well overdue. We're at 12 months now, but it might take up to 12 months. While this is good, it's good that someone could recover in 3 to 12 months, but take a minute to think about if an individual is going through a difficult time, how long and distressing 3 to 12 months is of experiencing even one of those symptoms. Additionally, this 3 to 12 months is that an individual might experience symptoms before three months, but is usually considered to be acute stress, and so technically would not be diagnosed as PTSD until after 3 months after an event. Sadly, however, and which is where I think we need to be very vigilant about what happens next, is the fact that most symptoms have a very long delay, and a delay of months up to years. One of the worst case scenarios of traumatic symptoms being delayed for years, meaning that an individual might be experiencing symptoms, but expressing it or it become full-blown PTSD did not happen for 50 years. Now that to me is a lifetime of pain for an individual. And it's frequently seen in research done with individuals in combat. You know, you've done everything to lock away this traumatic experience, but the hurt and the pain that comes with either concealing that trauma and the difficult outcomes that comes with it really destroys an individual's lives, but not just an individual, but the individuals around them. So our research tells us that there's multiple negative outcomes that comes from an individual going through trauma and having it buried, covered, or coped in negative circumstances. The first one is a loss with family connection. And again, temporarily, this is what we want. This is exactly what we want. You know, isolate, physically distance, stay away, just tough it out and have celebrations after. But experiencing it also causes the same outcome, where you do not want to be a person anyone wants to be around because your behavior is so negative or so hyperactive. Individuals might not know how to cope with this. Loss of job. And again, it's not lost on me that many individuals have lost jobs because of the pandemic, and in itself is a negative outcome. But symptoms of trauma can force behaviors that will cause an individual to lose their job. And the last one is the emergence of domestic violence, which is not something many persons would think about as a traumatic outcome. But coupled with the intense emotional reaction, negative mood, hyperarousal, an individual being easily startled, their behaviors are also very drastic and very extreme, and this is sadly one of the outcomes. Now, let's think about this on a little bit more of a positive note. So we know the risk factors, we know how it might present. What do we do? How do we cope? And I first want to talk about self, using an analogy of driving and seeing a car with brake lights. This to me is a warning. So when you see a brake light, you think, okay, there's something that I need to do. For the individual in the car, it might mean that they need to just stop for that time, but it might also mean that they need help. So I frequently think of this as, if you see this, what do you do? But it's telling you, even if you don't know what to do, something is wrong. On a personal level, one of my first suggestions is to take some time out. That pause, that break, that time to sort out what you might be feeling and to find out what exactly it is and where it's coming from is essential in starting that healing process. The next one is validating your individual feelings, because if we don't accept what we're feeling as different from how we used to be, then we find very genius ways to cover them up and excuse them for things. Individuals around us will also excuse them for just behaviors, just the way it goes. But essentially, what it does, it erodes us over time, which is the negative outcomes we talked about, which will lead to things like family separation or loss of job. As human beings, we cope, and we cope very good because we're resilient. But sometimes our coping mechanisms are negative coping mechanisms, and they are sometimes benign. So simple: caffeine, a cup of coffee, sometimes alcohol. We need to be aware when it becomes problematic, because the feeling of wanting to numb one's feeling away it's easy, sadly to say, but it doesn't necessarily fix anything long term. And probably the most powerful thing to think about is accepting that we cannot change everything. No one has gone through this before. I don't think there's many people alive who would have gone through the 1918 pandemic to know what to do. And even if we did, there were young children then. So everything we're experiencing now is new, it's different, and I don't think even our best scientists will tell you that they know exactly what the outcome is going to be. So just taking a pause, accepting the fact there are things that we can't change and won't change. But moving on from that. And next, I want to think about, what do you do for others? Because frequently we're able to see things that are happening to someone else much faster than we can see it in ourselves. There is a hesitance to deal with emotional mental disorders. I accept that there's many times that is considered a gray area. And the hesitance comes with, I don't know what to do, so therefore I do nothing. The good thing is that as human beings, we are all equal in emotions. We know what it feels like to love. We know what it feels like when you're in pain. We know the safety and security that a smile translates to another individual. So at the basis, we know what it feels when someone cares about us. So you might not know exactly what to do, but here are three very simple recommendations about what you can do if you see someone who is potentially suffering from the depths of trauma. The first one is just listening. You don't have to have the right words to say, but you give a listening ear, and maybe in that conversation, an individual is able to say how they feel, to process how they feel, and just knowing that another individual is on the line is good enough. Be forgiving. Like I said, this has been a whirlwind of emotional ups and downs, and not knowing what to do, not knowing the right thing to do. And sometimes the behaviors of a traumatic experience are negative. It's no one you want to be around or be around for very long, or you purposely avoid them. But in that, if you accept that some of the things that they go through, they're not even aware of themselves, and you forgive those mistakes that they make, that in itself is extremely powerful. And one of the mantras I try to live by is choosing kindness. So, giving a choice. Always choose to be kind to someone else. And maybe it's summed up best in this statement that says, a little spark of kindness can put a colossal burst of sunshine into someone's life. So do not underestimate the simple presence of being and what that might mean to someone. Now, as a clinician, I would be not wise if I didn't say what sometimes is the reason that I see clients in the first place. And that is because sometimes it's too much. It's too much for a family member or self to handle. And in those times, I would suggest that you reach out to someone else. There's much help available. And I will share with you two websites that are, one provides information in multiple different layers of how trauma is experienced, and this is PTSD, the Veterans Association. And there are times when you just need someone to talk to, and so I found this as a useful helpline for my clients. Connect 7417 as a place to find resources. So in closing, I would like to say that we are 12 months in, but we're not sure how far this is going to go. We need to be gentle and kind to ourselves as we process different elements of trauma. And to others, extend that hand of kindness whenever we can, because it might make all the difference. And above all, maybe there's a little light at the end of the tunnel. And with that light, maybe the next 12 months will be where we process, treat, recover, and adapt to what is our new normal. And with that, I will close and I will address some of the questions you might have in our chat box. So I'll start with Henry ask, what are the implications for the epidemiology of psychiatric disease? So fantastic question, Henry, and thank you for saying asking that question. So I try to think of psychiatric mental health disorders on multiple different levels, not just the epidemiology of it. And so one of the ways I practice is looking at what what is a biologic experience, and why is there some depth to just plain biology? But also, what is a life experience that might influence the way we think about psychiatric disorders? What is the behavioral component of of psychiatric disorders as well? And so I try to look at when I'm trying to figure out where a disorder might come from, that we look at multiple different components before we address it. And in that multiple component, we could see how the individual responds to those diseases as well. So I don't think it's a clear-cut answer, but one that comes on multiple levels. Jean asks, under what circumstances would you recommend trauma therapy? I am all for therapy, I would. And I would say, don't wait until it is disastrous. And I would want to just split two things. There's mental health and then there's mental disorders. Take away the stigma and shame of anything with the word mental. Being mentally healthy is a great thing. And so it's protective. It is, it should be encouraged. And I would say that trauma therapy should be a part of our lives, especially now, not because it's terribly bad, but because it's a protective element to how to deal with even the smallest of traumas. And Nikita asks, with choosing coping strategies, how do we go about understanding what are the truths about COVID during these repeated uncertain time? And that's an excellent question, Nikita. Thank you for asking. Part of what makes this pandemic so difficult is because there's much that we don't know and we don't understand, and we're expecting that know and that understanding to come from someone else. And within that, there is a truth, and that's what people will accept. And we have to accept that the reason why truth about diseases even comes up is because we do have a historical legacy which is not very good. And so with that there's doubt. There's doubt about what to believe and when to believe it. Um, there is the experience of trauma and how you cope. And so at an individual level, you will know the best coping strategies. What I would ask is that even as individuals, because we're resilient and we try to fix things ourselves, I will say if you're choosing coping strategies, try to choose the healthy ones. It's the simple things like going for a walk or connecting with a pet. But it's difficult even with my clients to say, I am recommending this therapy for you, because your body knows best, your heart knows best. It's the best healer that there is. And so you can dictate what works for you. And in that essence, you really want to be mindful about an individual's background and why they're going to choose a way to process or deal with the traumas that they're going through. We'll take another question from Sandra. And Sandra says, how would you transfer this knowledge to lead staff to transitioning healthy back into the working environment amongst colleagues and working on campus? Thank you, Sandra. That is so important. And truthfully, I've been working from home for over a year now, and I do have worries about what the work environment will look like. So we'll start by saying, I will start by saying by transferring this knowledge is first acknowledging what is going on. And I hate to sound like a broken record, but I think so many times we want things to be good. We want things to be open. We want things to go back to whatever normal is. And we're forcing that issue. And when we do go back to being in the work environment, we have to be sensitive to how individuals might react to our presence, might react to being in that environment again, and what kind of experience they had without you being present. What was COVID like for them? Because it was going to be very different from how you experienced it. You might have only experienced it the same as what comes in the news. You got the same news feed. But individually, that experience is going to be different. So give individuals time and space and understanding to allow them to have that journey back into this collective environment on their own terms. And I would hope that our administration and our school officials and work officials will take this into hand when we're trying to recreate the new work environment. Then I will. Another question asks, do you predict higher rates of PTSD with COVID-19 now or later once the world creates more normalcy? So I won't hesitate in saying this. Sadly, I do believe that it's going to be true, that it's at least for short term, it's going to be higher. Um, it is unfathomable to think that we would have gone through this without some scars, both on the physical end, 500,000 individuals dying. At minimum, there's a grief process there for at least times seven of those family members. So from that end, there is a traumatic experience that individuals need to deal with. But on the emotional end as well, this is like nothing we've ever been prepared to deal with before. And so that 8.7 lifetime experience, I sadly think that it will increase. I wish it weren't so, but everything tells us that it might be. Another question from Jennifer. Are there any specific things that we can do to support someone who exhibits a symptom of trauma but refuses to acknowledge it or seek help? And Jennifer, yes. Um, again, I go back to where we are afraid to address these things, and being confrontational is not the best answer to say, I know you're experiencing, but one of the best things to do is being present and being available for that individual and let them know that when they're ready and if there's anything they want to discuss, that you are available. It's very hard for an individual who is processing traumatic experiences or nightmare to even reveal what those are. But knowing that there's someone who can say, I'll tell you about it, I don't need your help, but there's just someone I need to talk to, that alone in itself is extremely powerful. Or just checking in on someone. How are you? You know, you're a little bit snappy at work today. Is everything okay? Just to check in to say that the person I know is not necessarily the person I'm experiencing now. Is there anything I can do to help? And you'd be most often surprised how comforting those words are. You're not giving an injection, you're not giving a vaccine, you're not giving a magic potion. You're giving of yourself, which is the best gift you could ever give to someone. I'll take another question from Karen. And Karen asks, what are the factors that impact full recovery and healing from complex PTSD? And so, Karen, I'm going to try and answer this question the best I can. So, statistics tells us that most individual will recover full recovery within 3 to 12 months. And this is just a process of how they process the traumatic experience, but the body in itself is resilient to go through this process by itself. There's no medications for PTSD, unfortunately. We will treat symptoms, and so it is aggressive therapy, trauma therapy that will often produce the best results. And for complex PTSD, individuals who have historical trauma, recurrent trauma, or cumulative trauma, accepting that this will take time and maybe a lifetime of addressing these symptoms with therapy. And so CBT is often recommended, but there are other forms that are used to process PTSD symptoms as well. And a question from Mary. Since trauma on occasion can lead to conditions such as somatic symptom disorders that are rare, where would you advise people to go for expertise on treating somatic symptom disorder? So thank you, Mary. And as a provider, I would want to say that one of the best things you need to do initially is to have a full assessment. And I will go ahead and say a full psychiatric assessment, taking away all the stigma, shame, blame, and guilt of doing that, but finding out what the symptoms are first, even before we make a diagnosis. And then, so you would want to either go to a psychiatrist, a psych nurse practitioner, or your medical provider. It could be your primary medical provider who can get you into specialist care. But at minimum, there needs to be very comprehensive psychiatric assessment. And whenever I do one, it usually takes at minimum an hour, and I know very little about that individual. So it's a process that takes time to know that individual, to first delineate if it's somatic or if it's real. And that is one of the reasons that individuals are usually shy about seeking help, because they don't know how their symptoms will present or it will be taken. But starting with finding out what it is first before an assumption, but certainly knowing that there is help when you have a better understanding of what is triggering some of these symptoms an individual might be experiencing. Um, Ed asks, PTSD sounds complex to diagnose. Are there any other ways to diagnose without waiting for individuals to verbally disclose their symptoms? And thank you, Ed, for that question. That's a question that I think might be my life's work. So as I said earlier in the talk, part of what I do is look at how trauma is developed into mental health disorders. One of the ways is to appropriately diagnose. Now, the reason why trauma is considered to be hidden is because we can't see a bleed or a rash or it's not presentable. So is there any other way to tell this? And so there has been some breakthrough of how we could better diagnose PTSD. Some of the work I did looking at traumatic brain injury and PTSD involves protein identification, again with the premise that after a traumatic event, um, the biology of an individual might change, which is manifested into bodily fluids, blood, saliva, sweat. And so one of the things I did was start my preliminary research and looking at changes in proteins in blood. It's not yet conclusive, but I think that might be one of the breakthrough ways. Like, is there a biological change that we could assess for trauma that might help us to diagnose earlier? Um, it goes a little bit more complex into proteins, but if you're up for reading, I would encourage you to look at IL-6, IL-10, and TNF alphas, proteins that are very strongly associated with post-traumatic stress disorder. All right. And from Susan, Susan asks, how can hospitals help protect their acute care teams who are experiencing a lot of lot of death in the patients they're caring for? And so as a healthcare provider myself, this hits very personal to me. Having worked in a trauma unit as well and knowing what the first-hand feelings are that you're doing your work and you're going through it, but you're human too. So two things. I want to address this from our healthcare workers who might be listening. When we do our jobs, the first thing we do is feel, and we know there's a professional boundary about how much we feel and how we express that. And I've always told myself the day I stop feeling is when I need to stop or step away from this job, because it is in that feeling of emotion and caring that I am able to do my best work. But there's a part where it becomes problematic where you also need to protect yourself. And I would advocate for every trauma unit, every intensive care unit, every hospital really, to provide that in-house support for their staff. Let it be there if they choose to use it or not. A hospital isn't your normal environment. It's only normal for sick individuals. And so there should be a component to debrief, de-stress, and a safe space to say, today was a difficult day. So my hope, my dream is that eventually every place of care would also care for their employees as well, not their physical care, but their emotional well-being. So that would be good if it existed, and I would encourage our nurse managers and our CEOs to have that available. And there's enough evidence after this how desperately difficult it is, but yet we won't walk away from a difficult situation. We'll always try to give of our best, regardless of how difficult this process might be. Another question from Caitlin. Caitlin asks, are there any recommendations on how we might practice the transition back to normal or larger social gathering to prevent overstimulation, particularly in children? Brilliant question. And for children, I have two young children myself, and so I worry about what going back to meet their friends might be. So, gentle transition in its best term, slowly. Um, I would also recommend, in the virtual sense, to start building back those connections before it happens in person. So there's a familiarity with who is it that you're going to meet, individuals' behaviors, and that there is some joy and expectation to that as well. That we are going back in an environment where, as children, they need to grow, they need that social connection in order to thrive. But how you do a year of separation back to full blown, a full classroom, should be guided, I think, in stages, and maybe smaller classrooms, and eventually whatever that normal playground environment is. But I would say start back at re-establishing phone calls or Zoom calls just to see, let me see my friend again. And so when we go back to whatever fall opening of school might be, it feels a little bit more that they had some time to transition back. Another question from Jennifer. Jennifer asks, how do we deal with society opening up when we've gotten so used to being isolated? So, Jennifer, again, isolation, loneliness is a piece that I worry deeply about, being so isolated. As human beings, we crave individual space, but more importantly, human contact. What has been more difficult about this COVID and getting sick is that we've seen where the time that you are lowest, the time that you need the most support, is the time that you're asked to separate. So everything from not being able to attend a funeral or celebrate birthdays you wanted to, or just having that normal get together, it's it's asking us to do everything that is humanly normal to do. How do we open up society? We need to be cautious. Cautious because there's emotional content where not everyone is going to want to rush back out into society. There might be individuals who still want to maintain their mask out of fear. And there might be other individuals who never believed anything in the first place and say, okay, let's go back. The vaccine is working. So there are going to be variable takes on why we should go back, how we should go back. And I think at the basis of this is just respecting individuals' right to decide. Respecting an individual to say that inviting me out because I'm vaccinated doesn't mean that I want to go out because there are personal fears I might be dealing with. And respecting that. So in the same way you would want to be respected to be joined and celebrated, you have to accept that an individual might have not experienced this the same way. They might have lost 5 or 6 family members, and you might have not lost any. And so there are different ways that individuals are going to process this going forward. And getting back out is probably not their primary goal in life at the minute. It's maybe just trying to survive. So just to repeat, it's there's no cookie cutter way to do this, but I think a little bit of patience needs to be injected and a little bit of respect for what an individual might want. A question from Henry. Any insights from your cross-cultural experience in mental hygiene? So, yes, and thank you for asking that question. As you might be able to tell, I do have an accent which is not traditionally American. So, one of the things I've looked at is how different cultures have experienced this and how it's been experienced in different cultures. Um, Again, there is the big part of mental health is the different stigma that's associated with it. And sadly, some of this is in a cultural aspect. But on the flip side of that, some of the good bits are in a cultural aspect as well. And how we deal with difficult times, trauma, is also culturally specific. Some persons, instead of isolating. They want to cook food for family, and that is their comfort. Instead of doing meditation, they want to call as many people as possible. Um, there's one aspect I mentioned about the historical trauma, and this applies specifically to cultural groups. And it's in this part as well that I also worry about how different cultures might be coping with this, having an historical aspect to their well being, um, and this being a cumulative effect of that, which might translate in what we're seeing of some of the vaccine hesitancies in what we're seeing with individuals. So don't assume that someone might be making a decision because they are vaccine naive, or there are other influencing factors. Some of them are culturally related, that is influencing how someone reacts, how they cope, how resilient they will be, and the decisions that they make about the COVID itself, as well as the process of healing. Um, from Craig, is there any research showing genetic or epigenetic indicators showing predisposition to PTSD? And the short answer is yes. And so part of that, going more to epigenetics to show how things change with the influence of trauma and how that might be passed down. So it's not yet conclusive to what might be associated with more widely studied schizophrenia and depression, about the genetic component. And there's a high correlation between individuals who have PTSD, first line family members. It increases the risk of your first line relative also having PTSD. That's often attributed to a biological change, not the only component, but it's definitely a part of that. Um, and with that, I would like to thank all of you again for your very thoughtful questions. Thank you for being so engaging. It was my pleasure. And I would encourage all of you to be kind to one another and continue to stay safe and take care of each other. Thank you.